then fracture lateral end of clavicle, then fracture of the olecranon, then fracture of the greater trochanter in femur. All right, fracture of the patella, just now we have talked about, we have dealt with the fracture of the patella, and fracture of the malleoli, mean medial and the lateral malleolus. All right, fracture of the malleoli. So these are the indications, means these are just the limited indications that I told you. Actually, the real result is that anywhere where the concept of this conversion of tensile into compressive forces is required, TBW can be used for the management protocols. All right, so this much you need to remember. So let's have a discussion on the management. We have already talked about this cylindrical cast, we have already talked about this tension band wiring. As you can see, the fracture is very you can see that there is no displacement. The posterior articular wall of the patella is not having any skip, not having any step, so the possible bending of the knee is going to have the best possible outcome for that. All right, so with this the patella fracture related questions, all the questions which could be asked out of this topic in particular, that is patella fractures, are done. You know, they are asking this question that patella fracture are treated by, and they are giving you some of the conservative examples like patellar tendon bearing cast, then cylindrical cast, then long leg cast, or below knee cast, likewise, or Jones cast, whatever. So these are the options provided. And majority of the time as a student, we tend to fall into the trap of getting it answered as patellar tendon bearing cast. But you know, PTB, that is patellar tendon bearing, is not used for the management of patellar fracture. It is used for the management of tibial diaphyseal fracture. So by the placement of a star, you have to write this point so that you do not get confused in future, that PTB, that is patellar tendon bearing cast, is used for, means what is the indication? It is used for the management of tibial diaphyseal fractures. That means tibial fractures. The tibial mid 1/3 fracture are managed by PTB cast, not the patellar fractures are managed by PTB. It is managed by cylindrical or the tube cast. All right, let's have a discussion on some of the eponymous fractures, that means named fractures in the lower limb. Floating knee, as the name indicates, floating means there will be a loss of continuation with the proximal and the distal part. So there has to be a fracture of distal femur, there has to be a fracture of proximal tibia, and there has to be a fracture of proximal fibula. So there will be a fracture of the proximal femur, distal femur, proximal tibia, as well as proximal fibula. All of them are fractured, as a result of which this knee joint has lost its connection, both proximally as well as distally. So it is floating in the knee. That is the reason why it is called as floating knee. It is relatively having a poor prognostic outcome because the bending of the knee is going to be affected. Late course of management is required with guarded prognosis. Next is runner fracture. No, you see, we have already talked about this kind of a fracture. Runner fracture is actually a stress fracture. It is the stress fracture of distal fibula. You know, if distal fibula is not there in the options, then you have to go for tibia. So it will be a stress fracture. That means because of the overuse of the bone, if there is a fracture of the distal fibula, if it is not there in the option, then you can go with the distal tibia. These are the runner fracture. As far as pylon fracture is concerned, pylon is also considered to be a plafond fracture. It is also known as plafond fracture. This pylon or plafond fracture actually is intra-articular fracture of distal tibia. Now, what do you mean by this term intra-articular fracture of the distal tibia? Just imagine if this is the distal end of the tibia, this is distal end of the fibula. If there is a fracture line which is extending all the way to involve the talar surface, that means the joint, then it would be called as pylon or a plafond kind of a fracture. All right. So these are the named fractures, eponymous fracture. Before we talk about malleolar fracture, hopefully everything is clear related to the patellar fracture shaft of femur as well as the eponymous fracture, that means named fractures in the lower limb. Now, let's have a discussion of a malleolar fracture. That means fracture around the ankle joint. That means involvement of the malleoli. So first of all, you should be introduced to that what are the malleoli which could be fractured. So before we talk before we talk anything related to the fracture, it is important to have a discussion of what exactly is a malleolar fracture. All right. So let's get introduced to the malleoli first of all. Imagine this is the distal end of the tibia and this is distal end of the fibula, and here we are having a talar bone. So this is the ankle joint. All right. Now this on the medial aspect, this is the medial malleolus. So the distal end of the articular surface of the tibia is actually the medial malleolus. Then the distal end of the articular surface of the fibula is the lateral malleolus. All right. Lateral malleolus. So these are the two malleoli. So most of the time what happens, there will be a bimalleolar fracture, trimalleolar fracture. Now what is that third malleoli? We are going to have a discussion under the section of trimalleolar fracture. But before we talk anything related to these malleolar fracture, it is important to have a discussion of the classification system. At least remember one classification system, that is Lodge-Hansen classification. All right. Now Lodge-Hansen has classified the fractures around the malleoli or the malleolar fractures into 4 different types. The type 1, 2, 3 and 4. Now you need not to go into the details of the outcomes of these fractures. You just have to remember the mechanism of injury which are responsible for causing the specific fracture of that type. All right. Now type 1 is the result of supination, adduction injuries. All right. Then type 2 is because of supination, external rotation injuries. Then type 3 will be a result of pronation, abduction injury, while type 4 will be a result of pronation, external rotation injury. All right. So you know what happens is they can give you a question that according to Lodge-Hansen system of classification, which of the following injury leading to malleolar fracture is not involved in causing the injuries around the malleoli. All right. So supination adduction, supination external rotation, pronation abduction and pronation internal rotation could be the option, and pronation external rotation is the correct answer for that. All right. So just Lodge-Hansen system of classification. If at all they ask this question, it will be for the first time they ask it. Now let's talk about the malleolar fractures in particular or in isolation. The first one is the Pott's fracture. Pott's fracture is the bimalleolar fracture. Now all of you know that what is bimalleoli. Bi means both the malleolus. That means there will be a fracture of the medial as well as lateral malleolus. Now Cotton's fracture is a trimalleolar fracture. Trimalleolar fracture. Now all of you know that bimalleolar means fracture of the articular surface of the tibia distal and fibula distal. So it will be bimalleolar. So what is trimalleolar? Trimalleolar is actually a bimalleolar plus posterior malleolar fracture. Now some of you might be getting confused that which one or which bone involvement is known to be a posterior malleolar fracture. The posterior malleolar fracture is not a fracture involving the talus. It is neither the fracture involving the calcaneum. It is the fracture of the posterior part of the tibia simple. So posterior malleolus is again a part of the tibia. So posterior end of the tibia, if it also is fractured, then it will be a unstable kind of the fracture which requires fixation and precise reduction of the ankle joint, which is known by the name of trimalleolar or the Cotton's type of the fractures. So these are the two fractures which you have to understand or remember as far as malleolar fractures are concerned. Then comes the aviator fracture. Now aviator is again an eponymous fracture. It is the fracture neck of talus. Now this fracture neck of talus is important for two reasons. One is its complication and the second one is the X-ray signs. So fracture neck of talus we are going to have a discussion on based on two reasons. Let's talk about the complications first. Now as far as complications are concerned, the first complication is avascular necrosis of talar body. That means body of the talus will be avascularly necrosed. And the second complication is non-union at the fracture site. That means non-union neck of talus. Because of the fracture in the neck of talus, there will be a non-union. Now, what is the reason? What is the important reason for this non-union? It is because of, again, precarious vascularity. It is because of the insufficient or ineffective vascularity. Now, how this ineffective or insufficient vascularity is responsible for causing non-union, just try to understand. Imagine this to be a talar bone. Alright, this is the dome, that means body of the talus, this is neck of the talus, and this is the head of the talus. Alright, this is the rough diagrammatic representation of the talar bone in the lateral view. Now, this region, neck region, this is the head of the talus, this is neck of the talus, and this is body of the talus. Alright, now the articular or the vascular arrangement to the body of the talus is such that the entire body is supplied by the vessels which are coming from the head of the talus. Alright, there is either very limited or no supply which is independent to the body of the talus. As a result of which, if there is a fracture in the neck of talus, then what will happen? This entire body of the talus will be devoid of the vascularity which is coming from the head of the talus, as a result of which it goes into avascular necrosis. That means avascular necrosis of the body of the talus. And the second, because of the same reason, these are the kind of the fractures which are more prone to go into non-union. So these are the complications. But most important or the most common complication, which is the third complication, which is secondary osteoarthritis. You know, secondary osteoarthritis is the most common complication. Why? Because if there is a fracture in the neck of talus, then even if it unites with the best possible reduction, even then there will be a secondary osteoarthritic changes. Alright? That means if there is no non-union, if there is no avascular necrosis, even then it will be having some osteoarthritic changes at the level of the ankle. The condition will remain painful for a long duration of time. Alright, so it is considered to be the most common complication. Now, if non-union is such a common complication, talar avascular necrosis is such a complication, then something or some X-ray findings must have been there in order to identify them. And this is visualized by Hawkins sign. Now, what is Hawkins sign? First of all, try to understand what exactly is Hawkins sign. You know, Hawkins sign is the sign which is based on the X-ray of the ankle joint in the AP view. Alright, but so you are taking the X-ray of the ankle in the AP view. Now that X-ray has to be taken at least 6 weeks to 6 months. Means somewhere in between, from 6 weeks to 6 months of, because for this duration of time it has to be observed from 6 weeks to 6 months of surgery. Suppose the patient came to you with the ankle fracture, talar neck fracture, and you have reduced it, because you know surgical intervention requires perfect reduction, anatomically perfect reduction, then only the possibility of non-union will be erased. Otherwise, higher are the chances that it might go into non-union and subsequent failure of the implant placed.